Hi, everyone. Thank you so much for joining us today. We will be starting here in just a moment with our webinar. First of all, I just wanted to take a moment to welcome everyone to today's webinar. We have placed all the lines on mute. However, I would also ask, as you're calling in, that you place your own line on mute, just to keep this. We are expecting a fairly large number of people to be joining us today. We will be having a question and answer session at the end of the presentation. You know, I do ask that as you think of questions, please go ahead and type them in chat, as we will go over these first and try to address them in potentially the upcoming slides. Also, the presentation slides were emailed to everyone earlier this week, and this webinar is being recorded and will be available shortly on the MetaStar website. And my name is Lori Manteufel. For those of you who don't know me, I'm a project specialist here at MetaStar, and I'm joined today by Elliot Hammer, who is coming to us from DHS and the Medicaid EHR Incentive Program. He'll be presenting some information as well, and he brought with him Janelle Safian, also from the Medicaid EHR Incentive Program, who is also here to answer questions. So I wanted to welcome everyone to, today once again. The objectives for this program, or of this webinar, really is basically preparation for 2017 Medicaid Meaningful Use Attestation. We're going to first be reviewing very briefly some of the changes to Modified Stage 2 in 2017. We will also be overviewing some of the 2017 attestation application changes, as well as new documentation requirements, and an overall overview of audit recommendations. And I will say this, we're going to be presenting an awful lot of material today, and this presentation is probably more intended for those of you who have been in the ForwardHealth portal in the past. For those of you who are new to the program or are not familiar with the portal itself, I've added a lot of links to resources, including the EHR incentive homepage on the ForwardHealth through DHS does have some excellent introductory videos, excuse me. And we also, here at MetaStar, will be offering additional educational opportunities coming up later in the year as well. So this is most certainly going to give everyone a flavor of what those changes are going to be. The other thing that I wanted to point out, as many of you probably are aware, is that in 2017, EPs do have the option to attest to either Modified Stage 2 objectives or Stage 3 objectives. However, what I found in working with many of you is that the reality is that the great majority of you are planning on attesting to the Modified Stage 2 objectives. Stage 3 objectives, although that is an option, does require an upgrade to the 2015 CERT standards, which, quite honestly, many vendors do not have available at this time. So today's webinar is really going to focus on the Modified Stage 2. All right, just very briefly, there's really only three objectives that have changed in 2017. The first objective, protect patient health information, which is basically a security risk analysis for review. In 2017, this does need to be completed within the calendar year of 2017. In previous years, it was permitted to do that up until attestation, but this year it does need to be completed within the 2017 calendar year. For objective number 8, patient electronic access, specifically measure number 2, which is view, download, or transmit. Most often this is considered to be part of your patient portal. This is increasing from 1 patient last year to 5% in 2017. And then objective number 9, secure electronic messaging. This also has increased from 1 patient in 2016 to a threshold of 5% in 2017. As I've been working with clinics over the past, well, since the beginning of the year, many clinics are looking for additional resources or ideas on how to meet and exceed those measures, specifically the VDT, the view, download, and transmit, as well as the secure electronic messaging. And I've listed 3 resources, and first of all, as I mentioned, we are going to be having an upcoming webinar on September 19th that is really going to be focusing on meaningful use success in 2017, so giving a lot of real-world examples of what clinics are doing. I also presented a webinar earlier this year, back in March, that we do have recorded that does have a lot of ideas as well, strategies for improving electronic patient engagement, and this hyperlink will take you straight to that recording as well as the presentation. And then another excellent resource is from the ONC, and that is the Patient Engagement Playbook, that also has a lot of good ideas and different strategies, many of which may be adaptable to your clinic. I did get a question regarding the security risk analysis, if it needs to be completed before the end of the 90-day reporting period, and the answer to that is really no. It just needs to be completed within the calendar year 2017, so it does not need to have a date specific to the 90-day reporting period. One other very quick reminder of an important change is that Adopt, Implement, and Upgrade, or AIU, applications are no longer accepted. Just a reminder that 2016 was the last year to initiate participation in the Medicaid EHR incentive program. Now, pay special attention if you do have any new eligible professionals that are entering your organization. That is something you're going to want to check. Many times, as you well know, your providers may not know if they previously participated or not. And the best source of information there is through the CMS website, specifically the registration and attestation system, and I've also provided a link to that. And I did have a question from in chat as well about the presentation, and yes, I'd be more than happy to send it out once again to all of the participants at the conclusion of this webinar, and it also will be available on the MetaStar website shortly. Moving on to the 2017 attestation applications changes. First of all, for eligibility, the standard deduction for the EP patient volume is 4.93%. As a reminder, that is the amount that you do need to take out of patient volume to account for CHIP encounters. The ForwardHealth portal is open right now, so if any of you do have eligible professionals where you know that they've met their 90 days of meaningful use, you can very much feel free to go ahead and attest for 2017 meaningful use for them now. That ForwardHealth portal will be open through the end of March 2018. And the EHR reporting period is 90 days for both new and returning participants, One thing that I wanted to make sure that we highlighted is that very recently we got some good news around the reporting period for clinical quality measures, or CQMs, and that is that it is now, CMS has clarified that it is now 90 days for both new and returning participants. That is a change from what you had seen in the ForwardHealth update that was published a couple months ago. So this is a very recent change, but very good news, since you'll be able to use 90 days for both new and returning participants attestation of the clinical quality measures. There also is a new CMS requirement, and that is Objective Zero, that is being called Objective Zero, if you want to call it that, when you go to attest. And this is a new CMS requirement. And since it's new, I am going to be spending quite a bit of time in the upcoming slides really digging into it.
Before we move on, Lori, this is Elliot Hamer from DHS, and hopefully some of you folks have heard my name before. We've corresponded over email. Before we move on, I just want to point out about the 90-day CQM reporting period for program year 2017. That's something that ruling came down from CMS, but it does affect our program. And Lori's very much on the pulse of the program and is sharing this information about the CQM reporting period being 90 days for all participants. And we just want to say from our perspective, sometimes it takes us a little longer to get this kind of messaging out. So I just wanted everyone to be aware that, yes, this does affect the Wisconsin Medicaid EHR incentive program, and that our team will be doing subsequent messaging to all program participants and laying out a timeline for any system changes that are required in order to meet the requirements that came down from CMS. So if you've been in our program before, you know these kind of changes have happened before late in a program year, and that just necessitates that we take a look and ask ourselves, okay, what do we need to do in order to comply with CMS? So just be on the lookout for messaging from our team pertaining to how can you comply with this 90-day CQM reporting period now. So thanks for sharing that information, Lori, and do expect messaging to come from us most likely early next week.
Okay.
I'm sorry, this is Janelle Safian. One thing I just want to interject is that I want to clarify that if you went into the system today, it would still it wouldn't reflect this new policy, right? So I just wanted to clarify that piece, that today the system isn't updated with this new policy yet, but like Elliot said, we'll be sending out messaging very soon about the next steps for that.
Okay.
I appreciate your patience with that.
Very good.
Thanks, Lori.
And with that, we're going to move into some of this new CMS requirement. And just to provide a bit of an overview as to what this is that really this is to support the information exchange and prevention of information blocking. As all of you are probably very much aware, interoperability is a high priority of health IT. And so this attestation is simply, in the most simple terms, your attestation that you've done everything that you are able to do using your EHR to support information exchange and prevent any information blocking, electronic information blocking. And also that you have been in cooperation with any requests that you had received or your organization has received from the ONC for direct review of the certified electronic health record technology as well, which is something also that is new this year.
And this is Elliot again, before we get into these specific questions, which I hope everyone, will follow along with, one thing just at the higher level to say is that you would know if this is happening, and that this is the bar. If you follow the links that Lori provided on the previous slide, once you get the deck and can take a look at it for yourself, the idea is that you're testing the fact that your organization is not willfully and outright information blocking or outright preventing the exchange of information or not complying with the ONC direct review. And my knowledge of the ONC direct review, I'm not sure if they have started these kind of reviews on site or anything like that. So the idea is that the bar is willfully, disregarding and actually, interfering with these processes willfully. And then it's not something that's, the idea is that you would know that it's happening. And so
exactly.
I want to say that, yep.
Exactly. But, of course, with all of these, many of these questions may be a little bit confusing, and
right.
So with that in mind and kind of have that legalese sort of feel to them, and so I've listed out the questions exactly as you will see them in the attestation. And we are in the process of putting together even a little cheat sheet so that you can have that available for you while you're doing your attestation as well. The first question is, do you and your organization acknowledge the requirement to cooperate in good faith with ONC direct review of your health information technology? Is certified under the ONC Health IT certification program if a request to assist in ONC direct review is received? And the answer does need to be yes in order to be a meaningful user. It just simply means that, if you received such a request, that you would cooperate with that. The next question is, did you or your organization receive a request for an ONC direct review of your health information technology certified under the ONC Health IT certification program? Now, this is a yes or no answer. So if you've received one of these requests, which I'll be honest, with the clinics that I work with and our program works with, we have not heard of anyone who has received this. However, if you have, the answer would be yes. This answer does not affect your meaningful use status at all. It's simply an attestation of yes or no. If yes, however, if you did receive one of these, did you or your organization cooperate in good faith? And I'm not going to read the rest of it, but basically it's saying, did you comply? Did you cooperate? And if you had received this, in order to be a meaningful user, you must attest that yes, you did comply. The third question under this section is, in addition, do you or your organization acknowledge the option to cooperate in good faith with the ONC ACB surveillance of your health information technology certified under the ONC Health IT certification if a request to assist in the ONC authorized certification is received? And this, once again, I don't believe that the answer actually affects meaningful use. Although, the idea is that you are attesting that you would be willing to. So the options are yes, no, or decline to answer. The next question is, did you and your organization acknowledge the option to cooperate in good faith with the ONC surveillance of your health information technology certified under the ONC Health IT certification program if a request to assist surveillance is received? And this, once again, is a yes, no, or decline to answer. And then one more question along these lines is, if yes, did you and your organization cooperate in good faith with the ONC and ABC surveillance of your health information technology certified under the ONC Health IT certification program? And this also has a yes, no, or decline to answer. In actions related to supporting information exchange and the prevention of health information blocking, The first question under this section is, did you or your organization knowingly and willfully, as Elliot had pointed out, the willfully portion of it, take action such as to disable functionality to limit or restrict the compatibility or interoperability of your certified EHR technology? And to be a meaningful user, you must attest no to this question. And then there's another section of questions under number 2 here. Did you and your organization implement technologies, standards, policies, practices, and agreements reasonably calculated to ensure to the greatest extent practicable and permitted by law that the certified EHR technology was at all relevant times? And you must attest yes to these in order to be a meaningful user, connected in accordance with applicable law, compliant with all standards applicable to the exchange of information, and then implemented in a manner that allowed for timely access by patients to their electronic health information, and implemented in a manner that allowed for timely, secure, and trusted bidirectional exchange of structured electronic health information with other healthcare providers, including unaffiliated providers with other certified EHR technology and vendors. And then the third portion of this, and final one, I may say, is did you and your organization respond in good faith and in a timely manner to requests to retrieve or exchange electronic health information, including from patients, healthcare providers, and other persons, regardless of requester's affiliation or technology vendor? And this also, your answer must be yes to be a meaningful user. And so those are all the questions that are now added into the attestation under, what is sort of being called Objective 0. And I just wanted to maybe open the lines just very quickly just to see if anyone had any questions, or else please feel free to use chat.
Dr. Nadine's office, could you hold, please? Thank you.
Did anyone have any questions at this point? Otherwise, I'm going to continue on. Okay. All right, very good. So next we are going to be going into the 2017 documentation submission requirements. And in this, there also have been a few changes as well. And Elliot, I don't know if you want to just sort of explain just a little bit of the reason why for these changes?
Sure, yeah. So Janelle can jump into if I don't cover this adequately, but the idea really is that, starting in program year 2016, CMS asked that we actually, have a more robust way that we're asking for patient volume information and certified EHR technology documentation up front. Basically, this idea of prepayment application review becoming a little bit more robust. And so the changes for the CERT documentation and for patient volume documentation that are reflected in 2017 are basically what we learned through the first year that we went through this process, and basically made it so that it's easier for organizations to email their applicable information to us all at once, rather than having some of the prior requirements, which were to, basically based on the number of eligible professionals in your organization, that your submission method of sharing that information with the state was dictated by, if you had more or less than, 30 EPs in your organization participating. So we've kind of, we took some of the lessons learned from program year 2016 and made the submission, a little more streamlined for everyone that wanted to share that information securely over email. So for the first two parts, we'll talking about how that's a little bit easier now. And then additionally, for the meaningful use dashboards and the security risk assessment requirements that are new this year, again, just the idea behind that is helping to streamline the application review process. So in program year 2016, when we required this information, we found out there was a lot of questions that on the prepayment review side that were to require outreach to your organization to try and clarify questions that may have come up. And the idea of having that information up front, just helps answer any kind of discrepancies that come up in the application review process, and helps. What we envision is that it will help payments, be as prompt as possible, and cut down on any kind of, back and forth with requesting additional documentation. So that's just kind of the high-level view of it. And then as Lori goes through and presents the next few slides, if there's any clarification that we can offer, we're certainly happy to do that.
One additional item. This is Janelle Sapien with DHS. Just one additional reason why we are asking for this documentation now. It's kind of in your benefit, because if you would get called upon for audit, the auditors have access to all of this information that we gather during your application review. So they actually take a look at that before they send out that audit request letter in the mail, and they might remove some or all of their requests, just depending on how much documentation is provided when you actually apply. So the more documentation that you submit with your application, the better off you are in case you ever get audited, because the auditors already have a chance to look at that, and then you're giving it to us at the time when you have it readily available, and not perhaps 2 years down the road. With staff turnover and such, we know that can be burdensome on providers when there are audits, when they do get an audit request letter. So I've heard that this actually helps expedite that process as well.
Okay, very good. And, just to sort of reiterate what you just said, Janelle, that was one of the positives that I really see is as I've helped people through audits. So often there's staff changes, and we will be discussing audits a little bit later on, but I think that this is really going to put organizations at an advantage, so that if they were to receive an audit, that there's much less trying to find the data that was used to support, which many times, even with the best laid plans, sometimes goes awry, and it's difficult to find that. Anyway, so just to once again just provide a summary about the 2017 documentation submission requirements. First of all, this is basically a lot of it is based right from there's the certified EHR technology documentation requirements, which is very similar to what you have been doing in previous years. Patient volume documentation, the only change really here, other than submission, is that the patient identifier for Medicaid patients must be either a Medicaid ID or a patient name. For all other patients, you can use a patient number, something internal. You're not really specific as to what would be needed for those other patients. But when you think about it, it makes sense. It's just proof that that you are meeting the patient volume requirement. And then also the meaningful use measure documentation is the other piece that also is new, and I'll be going into in a bit more detail. First of all, the security risk analysis, the new measure documentation requirements include for the security risk analysis, for modified stage 2 or stage 3, percentage-based measures, the meaningful use dashboard reports, or alternative source material. And then also we'll be discussing a bit about submission methods. For the security risk analysis or review, the SRA, as I've mentioned previously, must be completed prior to December 31st, 2017, and it must include the following: the approach for the assessment, the results of the assessment, and an indication of who performed the assessment. And the other piece that I just also wanted to point out is that if you did a review, so you did a formal review of a previous SRA, that you would want to also include the original SRA documentation as well. The other piece of it is just to make sure that it matches up, that the person who you are testing to perform the assessment should match the documentation supplied. So, you know, if it's a John Smith who's listed on the report as the preparer, that should be the person that you're also putting in the attestation portal. And then as detail on security updates are performed as a result of the SRA, the update made, and the date that that update was made. For percentage-based measures, this basically, I'm not going to go and read all of these, but it basically is, or most likely would be, your meaningful use dashboard report, okay? That's Plan A. For those of you who work with me, you know I always talk about that. However, if for some reason your EHR doesn't accurately calculate some of these measures, it is important to note that you are able to submit other information that also would support the attestation. And so that can be used as well if the meaningful use reports do not support that exact data that was entered. And I also wanted to point out that at this time, eligible professionals are not required to submit documentation supporting their clinical quality measures, only the meaningful use objectives. Submission methods, you can upload your documentation directly through the ForwardHealth attestation portal, and that's located on the submission page as it has been in previous years. All files must be either a PDF, an Excel spreadsheet, or a document format, and files may not be larger than the 2 megabytes. And however, the other way to submit for groups or for larger files is through the use of, is through email. I would be very careful, however, that you're using encrypted secure email for documentation containing personal health information, or also for your security risk assessment. Even though that doesn't have personal health information, it does most likely include information that you would not, that is private to your organization, that you would not want on the internet in general. So just a reminder on that. And then moving on to meaningful use audit preparation recommendations. And once again, this is going to be a bit of an overview. There's basically 2 sources of meaningful use documentation. One would be EHR documents, so any documentation that's derived directly from your certified EHR, so certified generated reports, or your MU dashboard reports that show the numerators and denominators, a sample of a Medicaid patient's electronic medical record, screenshots from your EHR, as well as audit logs from an EHR are all sources of data that could be used in an audit. However, there also are non-EHR sources of data, and this would include clinical policies and procedure documentation, written explanations, in the case of maybe using an alternate data source other than your EHR to show that you've met a measure, your security risk analysis, as well as documentation from the Wisconsin Division of Public Health, for example, for the public health measures, specifically immunizations. And then documentation for the percentage-based measures, This, once again, would be your EHR source data. This would be for objectives 3 through 8, as well as the non-EHR source data could be used for those objectives. And these are all the percentage-based measures. And then documentation, as most of you are probably very familiar with, some of the objectives are a yes-no attestation, specifically objectives 1, 2, 9, and 10. Although 9 this year actually is percentage-based. That's secure electronic messaging, and that is 5%. So I apologize, I need to update that. And there, once again, you'd be using EHR source data, but in this case, you'd most want to use screenshots to demonstrate the required functionality. For example, showing that you have the drug-to-drug and drug allergy checks turned on, or audit logs that validate actions. For example, enabling the clinical decision support interventions. You also would be able to use non-EHR source data, including clinical policies and procedures, written documentations, a letter from the EHR vendor as an example. And then also it is important to be able to provide documentation when you are taking exclusions, if they are applicable for you. And once again, that could come from EHR source data or also from non-EHR source data, as I've discussed earlier. This slide does show and is a really helpful tool based on each one of the objectives and sort of the kind of supporting documentation you would want to have and most likely be required to submit if you were audited. So I'm also not going to be going in great detail on each one of these objectives. If you do have specific questions, please feel free to reach out. I also wanted to point out that last year, and I do have the hyperlink, DHS did an excellent job. Janelle, I think you were the person who actually did that on supporting documentation along with auditors, and that's an excellent overview that goes into many more of the specifics on this topic. A few other very practical audit preparation considerations is that you do need to maintain all supporting documentation for 6 years post-audit. So plan for that. The best time to plan for an audit is prior to attestation. Make sure that all of your audit documentation is kept in a shared drive. Many times there's staff turnover, and many times I work with organizations that aren't able to find the reports that were run previously due to staff turnover. So this is a very important point. Creating what we recommend doing is to create an attestation file that's on a shared drive with all of the supporting documentation and have that all ready and available upon attestation. So at any point thereafter, you're ready in case of an audit. The other thing is to make sure that your denominators are consistent. There are a number of objectives that do all require, the denominator is basically all unique patients that were seen within an EHR reporting period, and something that is difficult, if not impossible, to explain is why those denominators would be different. And so make sure that those are consistent, and if they're not, make sure that you've dug into the reason why not, and that may be something that you need to explore with your EHR vendor. Elliot, were there any other comments, or Janelle, around audit recommendations or support that you wanted to add? Or common mistakes people make upon attestation?
I would say the biggest thing I can say for an audit recommendation is talk to your auditor. They are prepared and ready and willing to answer questions that you have. Obviously, if you're working with MetaStar, obviously you're going to pull them into those conversations, but don't hesitate to contact your auditor if you want clarity on what's being requested. Sometimes those requests are hard to interpret. What exactly is the auditor looking for? They're happy to talk to you. They're happy to have a phone call with you. You know, it's best to ask those questions and to open those lines of communication. I just can't say enough. If you cut off that communication, that's where it's going to get much harder for you, for them. It's going to push, you know, it's just going to make it much more difficult to get through the process. So, you know, definitely relying on your MetaStar resources, but, you know, if sometimes you have follow-up, certainly turn to your auditors. Their number is listed on the request letter. I know that, and I encourage you to use it.
And speaking from MetaStar's standpoint, I know I've worked with many clinics, as have my colleagues, and I also stress exactly what Janelle is saying, is that contacting the auditor, you know, especially if you need a little extra time or if you do have questions, it's never wrong to reach out to them, and honesty is just always the best policy. Mm-hmm. Very good. Before I open up the line for questions, I did just want to put in one more plug for our upcoming webinar that will be facilitated and presented by my colleague, Chris Becker, who will be talking about strategies for meaningful use success. And really the strategies are on the three most problematic or challenging objectives out there, and those for 2017, and that is objective number 5, the health information exchange. Objective 8, patient electronic access. So how do you get patients to view your portal, especially with difficult patient populations? And similarly around objective number 9, the secure electronic messaging. I do have to say that here at MetaStar we are collecting all of the strategies that different clinics have been trying, and so we have a lot of good information. There's no silver bullet here, but creativity is required. And so please register and join us in September for that important webinar. And it will be strategically placed right before the 90-day or the last 90 days of the year, if that is what you are planning on using for your reporting period.
And from the state's perspective too, we really do promote attendance for this webinar, and you know, going back and looking at the one, it was in March, the last one.
Yeah, it was.
You know, possibly reviewing that's publicly available on MetaStar's website, and just the idea being that, you know, it is kind of a try everything approach, and that Chris will be, you know, presenting strategies, and there will be open office hours. And I think part of what MetaStar is looking for and that the state is looking for too is for part of it to be discussion. If you've tried strategies that haven't worked and that's something that might be applicable, I think other organizations are willing to hear that too. So some of those cases where things have, you know, you've attempted strategies for you know, for patient electronic access, you know, for getting patients to view, download, or transmit, or for engaging in secure messaging, and, you know, if there's strategies you try that haven't worked, that's information that can be shared too, not just, you know, what has worked. So I think it's one of those things of, you know, taking kind of a community approach to it, and, you know, having you know, having everyone on the line hopefully come back and engage in this September webinar.
Mm-hmm. Okay, very good. And then I also promised some additional resources, and I have my favorites listed here. So, and then I also do most certainly have my contact information included here. In the chat there was requests for the slides, and I did go ahead and just send that out. to everyone in the chat. We can also send these out via email, and please feel free to reach out directly to MetaStar if you'd like to receive those. I'm going to go ahead and unmute the lines now. We do have about 10 minutes for questions, 10-15 minutes, so I'm going to go ahead and do that, or please feel free to continue to use chat. Right. I have gone ahead and did all of the lines. So if you don't have a question and there's background noise, if you wouldn't mind putting yourself on mute, we would all appreciate that.
Oh, I'm sorry. I just like heard background noise.
Oh, it sounds like it's over.
Hang your phone. Okay.
Well, I'm assuming that means I can hang up.
Here, one of the questions that came up, Elliot, is for the security risk assessment. What are you looking for specifically as part of the approach for the assessment? What kind of a documentation would be acceptable there? Is that something you guys would want to speak to?
Yeah, we can address that.
Yeah, so when we're talking about approach, we want to look at, talking about your methodology. What are the systems that you're looking at? Also, if it's, if this is something that was done in-house versus having a third party do this, we might be able to point you to other guidance that we already have. I think we have some information in the online handbook that has, and I apologize, I don't necessarily have it right in front of me right now, but I think we might have additional documentation about what might be included in there. The thing with a security risk analysis, though, is that it's largely going to be unique to your practice. So there are certainly guides, and I know MetaStar offers additional services to help prepare these documents, but it is going to be custom to your facility. So that approach, that actual documentation is going to look very different just depending on the size of your organization, and sort of the scope. But you want to talk to, scope is one of the things you'd want to talk to. So, and the different systems that you're looking at, and again, like I said, who sort of performs that? How is that analysis performed? Was it in-house? Was it somebody else? Was it multiple people? Lori, did you have?
Yeah, the other thing that I wanted to point out and point you to a couple of resources is CMS has a very good tip sheet on security risk assessments that really goes into a bit of what constitutes a security risk assessment. I think one of the misperceptions is that although many people do choose to contract with a third party to do a risk assessment, it's not something that is necessarily required. There also are online tools available. Many times the approach that's used, however, is sort of denoted right as part of whatever template, if you are using a template, is available. So for example, if you are working with MetaStar and the Medicaid Health IT Extension Program and you choose to use our services, we use one of the NIST approaches to that. And so if you're using something else, typically, and especially if you're using a third party, that's something that they typically spell right out in that final report. So does that answer the question? And or are there any other follow-up questions? Another question that came across the line along those same the same vein of questioning is, and are you also looking for up-to-date for updating the previous SRA when issues may have been identified, and what has been done to mitigate those issues.
Yeah, so I can speak to this a bit. So the requirement is that you do a security risk analysis, or you're making an update to one, or you're reviewing one. So if you've already completed one, you definitely do want to make sure that you're actually following through. It's not just, you know, the point of the security risk analysis isn't just because it's one of the meaningful use requirements, right? Like, the point is to really assess your systems, and we understand that things are changing and you're getting software updates, or maybe you're getting a new software in there. The point is so that you have a view of your systems and are ensuring that you're keeping electronic patient health information secure. And so if you have done a review and you identified some issues or some gaps, you definitely want to take that out and do a review of it, you know, for your next year. It's probably not a whole new review. It's probably just an update and a review of the previously completed security risk analysis. And then you'd want to, again, speak to the, you know, like Lori was saying, if you've made updates, you want to note when those were made and what those updates were and how those issues or gaps identified, how those were mitigated. So you certainly want to be doing that. It's kind of a building on process.
Yeah. You know, one other point that I would also like to add, Janelle, is that, you know, the CMS and ONC really have not given great guidance about what really constitutes an official review and what is enough. What our recommendation at MetaStar has been is to really look at the mitigation. Usually you have a mitigation section of your security risk analysis. So you'd want to go and document what has been done since your last review, but then also review everything you basically answered yes to. So even the policies and procedures, sort of the questions that you had in place previously, just to make sure that there haven't been any changes. And the other pieces is that we do recommend that you do conduct a full SRA whenever there's been a change in EHR or a major upgrade, as well as physical changes. For example, if you open a new clinic or you move to a new clinic, something like that really does constitute sort of the need really to go back and do a more complete security risk assessment. And the question did come up, so we're saying that you don't have to do an annual SRA, but can instead just update the previous SRA and how we mitigated the issue. And the answer to that is yes. However, this is really an organizational decision because of the fact that CMS nor the ONC has given clear direction as to what constitutes a review. Many times organizations, especially larger ones, will go ahead and enter into a multi-year contract, sometimes with a third party, or as an organization decide that every year they're going to do a complete security risk assessment. So that is, that's really up to the organization. For meaningful use purposes, Objective 1, protect patient health information, is very clear that it's either a security risk assessment or a review.
And we sent out a link to that CMS documentation, the risk analysis, security risk analysis tip sheet. So we do hope that in addition to some of the information that we're you know, providing on this call, that you're able to take a look at that tip sheet that CMS has provided. So it's a CMS tool on security risk analysis.
And I did go ahead and unmute the line, so if there are any further questions, we have about 5 minutes remaining. We would be happy to answer them. Okay. Well, I did want to thank everyone for their time today. I hope that you found this information helpful, and I wanted to thank Elliot and Janelle for coming. over today to MetaStar and doing this webinar with me as well. So I have gone ahead and put up my contact information here at MetaStar. Please feel free to reach out to us, and if you're not part of the Medicaid, if you're not a part of the Medicaid Health IT Extension Program, I'd be happy to share some information on the services that we are able to provide completely subsidized through DHS. So with that, I ask you all to enjoy the rest of your day. Thank you.